This is Matthew Tate presenting an instructional video on awake craniotomy and intraoperative mapping on behalf of myself and Dr. Hugues Defoe. During this presentation, we will discuss the initial management of glioma patients, concepts regarding the surgical resection of gliomas and the rationale for brain mapping. We'll then focus on preoperative brain mapping techniques, including fMRI, DTI, navigated transcranial magnetic stimulation, and neuropsychology assessments. We'll then move on to intraoperative mapping, general indications, techniques, and patient examples, and we'll finally end with some conclusions. In a patient initially presenting with a suspected glioma, we should first stabilize the patient clinically. This may require anti-epileptic drugs if the patient presents with a seizure and/or intubation, mannitol for elevated intracranial pressure, and/or steroids for edema. We should then perform a thorough neurologic examination, focusing on mental status, sensory-motor function, and language. Initial imaging would be a non-contrast CT scan to look for mass effect and/or bleeding. Once a glioma is suspected, an MRI with and without contrast and flare sequences should be performed. For the scenario of a flare-positive, non-enhancing lesion, for which there are other etiologies on the differential, we may consider repeating an MRI in 3 to 6 months to look for volumetric growth of the mass to confirm the diagnosis of glioma. And finally, we should focus on whether treatment should be performed in an elective versus urgent versus emergent nature. Key surgical concepts in the treatment of gliomas are first to establish a diagnosis, keeping in mind that gliomas can be quite heterogeneous and there may be a sampling error with a biopsy. We would also want to maximize the extent of resection, as this has been shown to improve outcomes in all grades of intrinsic infiltrating gliomas. On the other hand, since surgery is not curative, we must do so safely, and thus brain mapping comes into play. Other reasons for performing surgery including reversal of neurologic deficits caused by mass effect, for example, and to improve seizure control, whether that's freedom from seizures, a decrement in medication requirements, both of which would improve the patient's quality of life. Shown here are 2 studies demonstrating that with increasing extent of resection, we see an improvement in overall survival, both for low-grade gliomas, shown on the left, as well as high-grade gliomas on the right. Given these data showing improved outcomes with aggressive cytoreductive surgery in low and high-grade gliomas, the goals of modern tumor surgery are to resect as much tumor as possible, but on the other hand, given that we cannot cure the patient, to minimize permanent neurologic deficits, and it is here that brain mapping is key. Brain mapping consists of preoperative and intraoperative mapping techniques. On the preoperative side, we utilize functional MRI, diffusion tensor imaging, and other modalities. Nonetheless, intraoperative brain mapping remains the gold standard, as it allows us to identify areas of the brain that are crucial for a given function. We can also map not only brain surface but deep structures as well. This can be performed in the awake or asleep setting, and we can utilize this map to plan a safe entry and trajectory, and most importantly to define functional boundaries where we should halt our resection. In summary, the intraoperative brain mapping allows for a more aggressive resection while minimizing the risk of permanent neurologic deficits, which is our goal. Shown in this slide is a panel from a study in 2012 which nicely demonstrated that intraoperative mapping allowed an increase in extent of resection while minimizing neurologic deficits despite the dealing with tumors that were nearer to eloquent areas by definition. Now let's take a look at preoperative mapping techniques. First and foremost, it is critical to have an understanding of the brain anatomy itself. First, we'll start with the lateral surface anatomy of the brain, as this is the most commonly encountered in surgery. Shown here is the precentral gyrus, of course the primary motor area. Central sulcus is here, followed by the postcentral gyrus. Next we'll move over to the frontal lobe. Here's the superior frontal gyrus, middle frontal gyrus, and inferior frontal gyrus, which can be divided into the pars orbitalis, triangularis, and opercularis. Shown here is the ventral premotor cortex, which is a common site for speech arrest within the inferior portion of the precentral gyrus. Moving on to the temporal lobe, we have the superior, middle, and inferior temporal gyrus. In the parietal lobe, we have the superior parietal lobule here. We have the supramarginal gyrus just behind the postcentral sulcus, as well as the angular gyrus, divided by the Jensen sulcus. On the medial side, here we see the cingulate sulcus ascending into the marginal sulcus, which is equivalent to the postcentral sulcus. Central sulcus here, paracentral lobule here, representing the sensory motor foot area. Now we'll move on to some examples of functional MRI as it relates to glioma surgery. Here are two examples of patients with low-grade gliomas with preoperative functional MRI and intraoperative direct electrical stimulation based maps. On the left, we see a left frontal tumor highlighted in red, and just posteriorly, motor activation sites for the lip in yellow and tongue in green. Below, our intraoperative map shows nice correlation with stimulation-based activation of the lip in yellow and tongue in green. On the right side, we see a left insular low-grade glioma highlighted in yellow, as well as activation sites for various language paradigms in the fMRI scanner. Below, during a picture naming task, we see critical sites here in the inferior frontal gyrus and more superiorly here. Of note, while there is certainly a correlation between those two sites and the preoperative fMRI, there are also additional sites seen on fMRI which did not elicit naming errors during stimulation in the OR. In summary, fMRI can be a useful adjunct to identify candidate regions of interest for stimulation in the operating room. It may inform us about involved areas, but not necessarily critical areas for a given function. Next, we'll move on to diffusion tensor imaging. Shown here is the corticospinal tract as determined by diffusion tensor imaging posterior to the tumor. The sagittal plane here, we see again the corticospinal tract posterior to the tumor, as well as the inferior frontal occipital fasciculus, the longest white matter tract in the human brain. This slide illustrates the real utility of DTI in that it can show displacement of large tracts by the tumor, which can assist with preoperative surgical planning. Now we'll move on to navigated transcranial magnetic stimulation. Here's a case example of a patient with a left frontal glioma for which we performed preoperative navigated transcranial magnetic stimulation. In particular, stimulation at this site within the inferior portion of the hand knob of the precentral gyrus. We elicited a motor evoked potential in the hand. Navigated TMS is primarily used for motor language mapping. It is nice in that it's a non-invasive method and does somewhat approximate direct electrical stimulation that we do intraoperatively. In addition, one can test both hemispheres with navigated TMS, and it lends itself to performing serial studies postoperatively to look for changes in motor and language maps. Finally, there is some recent data demonstrating that utilizing positive motor sites determined by navigated TMS to seed portions of the corticospinal tract with diffusion tensor imaging can be useful in determining the risk of a postoperative significant motor deficit for tumors involving the primary motor cortex. The final modality we'll discuss with respect to preoperative mapping is neuropsychological assessment. We certainly advocate for comprehensive neuropsychological assessments of patients before surgery with regard to attention and executive function, motor, language, emotion, mental flexibility, visuospatial processing, mood, memory, and processing speed. These assessments, in addition to being performed preoperatively, are also performed at 2 weeks, 3 months, and 6-month intervals postoperatively to assess for changes in cognitive function. The main goals of this neuropsychological assessment in the preoperative setting are to define overt neurologic deficits, to determine if the patient is an ideal candidate for mapping, to choose proper tasks for intraoperative assessment, both the modality as well as a level of difficulty given a patient's preoperative status, and finally, serial assessments over time postoperatively can be useful in determining plasticity as it relates to management of glioma patients, and particularly low-grade gliomas. So how do these preoperative mapping adjuncts help us? In terms of surgical planning, diffusion tensor imaging can inform us about displacement or overt destruction of critical white matter tracts. Functional MRI and transcranial magnetic stimulation can give information regarding language dominance grossly, as well as candidate regions of interest that we may want to stimulate intraoperatively. Neuropsychological assessments can help us to predict functional declines postoperatively, help us choose the appropriate mapping modality, and to assess whether a given patient is appropriate for awake surgery. In summary, these increase our efficiency of intraoperative stimulation-based mapping by demonstrating the proximity of the tumor to presumed critical cortical and white matter regions. While preoperative mapping modalities can certainly be helpful in surgical planning, there are important limitations that must be considered. With regard to fMRI, there are many false positives and if relied upon completely, the surgeon may be too aggressive or not aggressive enough. And I think most importantly, at best, fMRI tells us which areas of the brain are involved in a given function, but not which are critical, and this must be kept in mind. For diffusion tensor imaging, it's important to consider that these are mathematical constructs subject to assumptions in seeding paradigms, and also that edema near the tumor can alter tract propagation, leading to false negatives. For navigated transcranial magnetic stimulation, it has been shown to be very accurate for motor mapping relative to fMRI or direct electrical stimulation. However, the reliability of language testing is a concern, as the ideal stimulation parameters have not been worked out to date. In addition, mapping of language function within the temporal lobe can cause some patient discomfort from contraction of the temporalis muscle. Now we'll move on to the gold standard, which is intraoperative mapping with the direct electrical stimulation. The main indications for intraoperative mapping during tumor surgery include: number one, if the tumor itself is in or near functional areas of the brain. This is classically included in language or sensory motor regions, although more recently this has been expanded to vision, spatial attention, or really any area of cognition that is important to the patient. Or if the pathway to the tumor may involve a critical area. Contraindications to intraoperative mapping include the patient can't perform the task efficiently due to pre-existing neurologic deficit, mass effect or midline shift, which may be a concern from the neuroanesthesia perspective, as well as any other airway concerns, or finally, patient factors such as anxiety or poor cooperation. The benefits of awake mapping include a higher fidelity map, particularly for tumors in the motor and sensory areas. There are, of course, some functions that can only be tested in the awake state, and awake mapping typically requires a lower current intensity relative to asleep mapping, therefore lowering the risk of intraoperative seizures. Limitations of awake mapping include a dependency upon a cooperative and efficient patient participation, length of surgery, neuroanesthesia concerns, which primarily revolve around keeping the patient somewhat sedated while maintaining adequate ventilation, neurologic deficits such as inability to do picture naming accurately or major weakness for motor mapping, and finally, some neurosurgeons and or neuroanesthesiologists are uncomfortable doing major procedures awake. We feel that it's important to have a dedicated team involving neurosurgery, neuroanesthesia, neuropsychology, and speech therapy to interpret patient function in real time. And ideally, the team would be performing 2 to 3 of these procedures per week. So how is intraoperative mapping actually performed? For the asleep mapping scenario, the patient is placed under general anesthesia, and we stimulate the cortical surface and subcortical structures. And what we're looking for here is a motor response, either an overt movement or a motor evoked potential. In the awake mapping scenario, local anesthesia is applied either via ring block plus pin site injections or a full scalp block. Patients are either asked yes or no questions during stimulation for motor and sensory mapping, or errors in performance are noted during stimulation for language, vision, attention, or other cognitive domain mapping paradigms, as interpreted by the neuropsychologist or speech therapist sitting with the patient. An important adjunct to intraoperative mapping is monitoring of function, where we continuously evaluate the patient's performance even when not directly stimulating. Listed here are tasks commonly employed at our center: traditional motor and sensory stimulation, counting, picture naming, reading, visual spatial assessment using a line bisection task, a motor coordination task where the arm and leg are simultaneously moved during stimulation, optic radiations, multiple languages, and a multimodal double task where the patient is asked to flex the arm in sync with a picture naming paradigm. This allows online assessment of attention, motor, sensory, language, and vision. Shown here is a typical setup with the patient in a lateral position and the head immobilized in a Mayfield head holder. Here is a typical exposure one might see during intraoperative mapping. For reference, this is the left-sided sylvian fissure, this red dotted line, pars triangularis and pars opercularis with the inferior frontal gyrus, the inferior portion of the precentral gyrus and postcentral gyrus here, superior temporal gyrus here. One can note the very expanded posterior portion of the superior temporal gyrus corresponding to the tumor. In this particular case, stimulation at site 1 during counting elicited speech arrest, which is in the ventral premotor cortex of the inferior portion of the precentral gyrus. In addition, stimulation at site 2 within the supramarginal gyrus during picture naming elicited a dysnomia. For direct electrical stimulation-based mapping, we utilize an Ogeman bipolar stimulator. Parameters include a 50 to 60 Hz, 1 to 2 seconds of duration, biphasic and bipolar probe. The rationale for this includes extensive clinical data, as this type of stimulation is considered the gold standard, its ease of use, and minimal current spread, allowing for precise field of stimulation, as modeled here. Now we'll move on to some examples of cases involving intraoperative mapping. First, sensory motor. Shown here is direct electrical stimulation based map of the primary motor and sensory cortices of a patient harboring a lesion within the anterior portion of the hand knob of the precentral gyrus on the right side. One can see the high spatial fidelity of the expected somatotopic distribution of function in these regions, as described in the text below. In this example, there's a tumor within the posterior portion of the superfrontal gyrus, as shown in yellow here. Diffusion tensor imaging is overlaid. Most relevant, the corticospinal tract here, which is immediately adjacent to the posterior inferior aspect of the tumor. On the right side, we see primary motor cortex stimulation at sites A through E, eliciting the expected motor responses. In addition, at sites H and I, during subcortical stimulation, movement of the arm and leg were noted via direct stimulation of the corticospinal tract. The corresponding areas are noted here for A through E and H and I. This patient has a low-grade glioma within the supplementary motor area, as shown here, anterior to the paracentral lobule. On the left is a fMRI map showing primary leg sensory motor activation in purple, as well as presumed supplementary motor activity activation in yellow, here just anteriorly. On the right we see the intraoperative mapping details from direct electrical stimulation. As expected, foot motor and sensory activation was seen at sites D and N respectively. In addition, stimulation at site Q in the depth just anterior to the precentral sulcus elicited hesitancy of movement when the patient was asked to perform concurrent arm and leg movement, which corresponds to the area of supplementary motor activation shown on fMRI. Of note, stimulation at site Q during movement of either the arm or leg in isolation had no effect. Next we'll move on to articulation. Shown here is an example of a patient for which stimulation in the middle and inferior portion of the precentral gyrus during counting and picture naming tasks elicited dysarthria. Now we'll move on to language mapping examples. Shown here is a patient with a very large left-sided middle frontal gyrus mass. Anterior to the primary motor and primary sensory areas. During a picture naming paradigm, stimulation at sites U and V, here within the pars opercularis, as well as at site T, here in the supramarginal gyrus, elicited frank anomias. Shown here is another example of direct electrical stimulation map during picture naming. On the left, where dysnomias were elicited during stimulation of the pars triangularis, the left side. On the right is an fMRI map taken in the same patient. We showed some correlation in this region, but also additional areas that were positive on fMRI, which did not elicit naming difficulty during stimulation. With regard to mapping of subcortical language pathways, there are three major white matter bundles which we are concerned with during intraoperative mapping. The first is superior longitudinal fasciculus / arcuate fasciculus, which constitutes the so-called dorsal phonologic stream connecting the frontal and posterior temporal regions. Within this, the arcuate fasciculus is the deeper pathway and again contributes to phonological processing. This connects the middle and inferior temporal gyrus to the middle and inferior frontal gyri and can be found during stimulation at its anterior extent deep to the insula in the external capsule. At its midpoint, deep to the supramarginal gyrus in the inferior parietal lobule. And at its posterior inferior termination within the junction of the middle and inferior temporal gyri. More laterally and superficially, the SLF3, which is involved in articulation, connects the ventral premotor cortex to the inferior parietal lobule. Stimulation of the SLF3 and arcuate cause articulation and phonologic errors, respectively. The next major white matter bundle we are concerned with is the inferior frontal occipital fasciculus, which constitutes the ventral semantic stream. It connects occipital basal temporal regions to the frontal lobe diffusely. This can be found during stimulation anteriorly, deep to the dorsolateral prefrontal cortex and Broca's area, at its midpoint, anterior and inferior to the arcuate fasciculus, deep to the insula, in the temporal lobe, within the roof of the temporal horn, near the inferior circular sulcus, and posteriorly within the superior sagittal stratum. Stimulation at any point along the IFOF causes semantic paraphasias. Lastly, the inferior longitudinal fasciculus, which is involved in reading, can be found inferior to the optic radiations, and stimulation of this white matter bundle results in overt alexia. Illustrated here are the aforementioned white matter bundles projected onto the template brain. Here's superior longitudinal fasciculus underlying the frontal parietal operculum, as well as the posterior portion of the superior and inferior temporal gyri. Deep to this, the arcuate fasciculus loops around the insula, connecting the temporal lobe to the posterior inferior frontal lobe. In the lower left, the inferior longitudinal fasciculus is shown deep to the middle temporal gyrus. And finally, the inferior frontal occipital fasciculus, a long white matter bundle extending from the occipital lobe posteriorly and terminating diffusely within the frontal lobe. Shown here are two examples of positive subcortical stimulation during language paradigms. On the left is a large left-sided temporoccipital tumor, the resection cavity of which is shown here. The resection was halted at its depth due to positive stimulation of the arcuate fasciculus here in blue and inferior frontal occipital fasciculus in green. Shown below are diffusion tensor imaging snapshots of the arcuate and inferior frontal occipital fasciculi as they relate to the high-grade glioma here. On the right, we see the case of a patient with an insular tumor on the left side, for which stimulation of the arcuate and inferior frontal occipital fasciculus served as the deep functional margin. Shown here is a distribution of all positive sites in a large series of low-grade glioma patients undergoing awake surgery with direct electrical stimulation. Of note, the overwhelming majority of anarthria and overt speech arrests localizes to the inferior portion of the precentral gyrus just above the sylvian fissure and not within Broca's area. However, stimulation within Broca's area, as well as the classic Wernicke's area, did elicit true language disturbances, as evidenced by anomias and dysnomias of these distributions. A similar distribution of speech arrest and anomia sites were observed in the right hemisphere of left-handed and ambidextrous patients. Now we'll move on to mapping of the visual pathway. Shown here is a left temporal-occipital low-grade glioma. On the left panel, we see fMRI analysis showing the primary visual cortices activation. On the right, we see diffusion sensor imaging showing the optic radiations in green, identified with the white arrows in immediate apposition to the tumor. In this particular case, we are willing to accept a superior quadrantenopsia given the location of the tumor, but the goal of mapping is to avoid damage to the inferior quadrant of the right hemifield. To this end, we employ a variation of the picture naming paradigm where two pictures are presented opposite one another, and this is alternated with each stimulation. Utilizing this task, we are able to achieve a reasonable resection as demonstrated in postoperative FLAIR imaging, and the patient only experienced a superior quadrantenopsia with preservation of the inferior quadrant. Finally, we'll move on to visuospatial function. To assess visuospatial function, we utilize a variation of the line bisection task where the patient is presented a line segment and asked to mark the midpoint with a pen. Most commonly, this is performed during surgery in the right hemisphere where stimulation elicits a rightward deviation of the line bisection. Shown here are summarized data from patients undergoing visuospatial testing intraoperatively, revealing a distribution of positive sites within the right inferior parietal lobule and posterior temporal lobe. In conclusion, the goals of glioma surgery remain to establish a diagnosis and remove as much tumor-involved brain as possible, as increased extent of resection, improved survival, seizure control, and patient-related quality of life. On the other hand, given that surgery is not curative, we must consider functional consequences of our resection. Brain mapping allows us to predict and maintain this oncofunctional balance, and it remains that direct electrical cortical and subcortical stimulation-based mapping is the gold standard for determining whether a given brain region is critical and must be preserved versus functionally compensable.